During pregnancy, a new structure called the placenta grows to deliver oxygen and remove waste from the fetus's bloodstream. The placenta begins as a shell of cells around the embryo called trophoblasts. This attaches to the lining of the mother's uterus called the decidua. The trophoblasts become several different types of cells as they grow and divide. Some trophoblasts become structures inside the placenta called villi. As they grow throughout the pregnancy, the villi branch into the shape of a tree. Inside the villi, blood vessels develop that will connect to the baby's umbilical cord. At the base of some of the villi, another type of trophoblast helps hold the placenta in place. Normally, these cells move into the decidua. Chemical signals from the lining of the uterus tell the cells how far to travel. Some travel a short distance into the muscle of the uterus, which is called the myometrium. These cells also take control of the arteries that will carry oxygen and nutrients to the placenta. They make arteries larger, allowing them to carry more slow-moving blood to the fetus, which helps it grow. About 12 weeks into the pregnancy, the placenta begins to do its job as blood from the mother surrounds the tree-like villi and delivers oxygen and nourishment to the fetus. As time goes on, the placenta will continue to grow as it supports the fetus. After the baby is born, the placenta will separate from the uterus, pushed away by the strong contractions of labor. Normally, the placenta implants at the top or along the side of the uterus. A placenta covering the cervix is known as Placenta Praevia. This may occur with another condition known as placenta accreta spectrum. Placenta accreta spectrum, or PAS, occurs when the placenta does not attach normally to the uterus. It can be divided into 3 categories based on how deep the attachment goes: placenta accreta, placenta increta, and placenta percreta. PAS increases the risk of serious bleeding during childbirth due to the large volume of maternal blood in the placenta. PAS can be caused by scarring in the uterus, which can happen after surgeries like cesarean section. PAS usually happens low in the uterus at the same location as the C-section scar. In areas with scar tissue, the lining of the uterus can be abnormal, which might make it easier for trophoblasts to invade. In placenta accreta, the placenta attaches directly to the muscle of the uterus instead of the uterine lining. In placenta increta, the placenta invades the muscle of the uterus. In the absence of a normal uterine lining, the placental cells continue their journey deep into the muscle of the uterus. Because of this, larger arteries deeper in the uterus also grow and change. Lastly, in placenta percreta, the placenta invades the full depth of the uterus, all the way to the outer layer called the serosa. When this happens, the placenta may be able to grow into other organs in the pelvis, such as the bladder, and may also be able to influence blood vessels outside of the uterus. Placenta percreta can be especially dangerous. Because the placenta is so strongly attached to the uterus, this increases the risk of serious bleeding during childbirth. If ultrasound shows possible PAS, other imaging tests may be needed to help create a safe plan for delivering the baby and decreasing the risk of bleeding. An MRI can help your team of doctors see whether the placenta extends outside the uterus or involves organs like the bladder, vagina, or pelvic blood vessels. PAS can increase the risk of significant bleeding during childbirth, which can lead to a rapid decrease in blood pressure, shock, and multi-organ dysfunction and failure. Seeing doctors at a specialized treatment center during pregnancy can lessen the risks of dangerous bleeding during childbirth. These doctors all have different skills that help them care for patients with PAS and will work with you to create a plan to safely deliver your baby. Usually, this will involve early delivery of the baby through the top of the uterus in a special type of C-section. The placenta stays inside of the uterus after the baby is born and is removed along with the uterus. This is called a cesarean hysterectomy. The ovaries are left in place, allowing the possibility of future pregnancies through gestational surrogacy. Specialized care from the Johns Hopkins Placenta Accreta Center may decrease the risk of complications during childbirth and improve the safety of you and your baby during pregnancy and delivery. The team will continue to work together after delivery until mother and child are full.
Antepartum hemorrhage. So antepartum hemorrhage refers to bleeding occurring after 24 weeks of pregnancy. There are a number of causes one must consider. So we've got placental abruption, placenta praevia, vasa praevia, and uterine rupture. Other causes then include any incidental findings, such as cervical lesions or polyps, infection or trauma. While in some cases, the cause is not determined, and this falls under the category of undetermined origin. Okay, so if you haven't watched them already, now would be a great time to take a look at my videos on placental abruption and placenta praevia. These are the two most common causes of APH, so here I'm going to focus on how we can differentiate between them in a clinical setting. So first of all, in placental abruption, the condition is associated with a significant amount of pain. The pain is constant in nature, irrespective of the contractions. While on the other hand, placenta praevia is not associated with any pain. Therefore, in placental abruption, the uterus will be tender and sometimes hard, while there is no tenderness in placenta praevia. Now, in terms of bleeding, there may be absolutely no bleeding in placental abruption, as you may have a concealed abruption. Or instead, there may be small amounts of old dark blood. While in placenta praevia, there is a good amount of fresh red bleeding. Now, because of the possibility of the amount of bleeding being hidden in a concealed abruption, shock in the patient will be inconsistent with the bleeding observed in the vagina, while in placenta praevia, a lot of bleeding will be noted in the vagina, and therefore shock will be consistent this time with the external loss. Now, in placental abruption, the fetal lie is normal and the head is engaged, while in placenta praevia, because the placenta is in the way, there will be an abnormal lie of the fetus and the head will be high. Next, so since in placental abruption the placenta is detaching from the uterine wall and the blood supply to the baby is being affected, fetal distress may be observed. If the placenta completely detaches from the uterine wall, therefore receiving absolutely no blood supply, the fetus may also be dead. While in placenta praevia, it is merely the placenta which is bleeding, so the fetal heart will be normal. Finally, of course, when performing an ultrasound, the placental location will be normal in placental abruption and low in placenta praevia. Keep in mind over here that most of the time an abruption cannot be identified on ultrasound, so the diagnosis of placental abruption is a clinical one. Great, so this is very important to know and comes up quite a lot during exams. Good, so next let's move on to discuss briefly the other causes of APH. So we've got vasa praevia. So vasa praevia is a rare condition that occurs when fetal blood vessels cross in front of the presenting part through the fetal membranes, as we can see in the image over here. So essentially what happens is that when the membranes rupture, the fetal blood vessels within the membranes also rupture, and this is called ruptured vasa praevia. Of course, because we are dealing with direct blood supply going to the baby, ruptured vasa praevia is usually accompanied by severe fetal distress. Great. Finally, we have uterine rupture. So this is when literally there's a rupture of the uterus. This usually occurs during labor in a woman with a previous C-section scar or else a uterine scar secondary to previous surgery, such as a myomectomy. This part of the uterus will be weaker, and with contractions during labor, this weak point can give way, resulting in uterine rupture. So just